All right, thank you again. I'm Mark Hardin. I'm a new cardiothoracic surgeon here and excited to join the team at Arkansas Heart Hospital. I'm going to talk today about a group of patients that can be really a challenge to manage, both from a surgical standpoint, but also from a medical and social standpoint as well, and that's patients with drug-related endocarditis. And so we all know that the opioid epidemic has reached crisis levels across the United States and certainly here in Arkansas as well. And I know the audience is fairly mixed. A lot of primary care, ER, in the operating room, and people that work across the hospital are coming in contact with these patients. And so I've got a few learning objectives to go over. I think they're fairly simple but important to know. One is that the incidence of drug-related endocarditis is increasing over time, as is the cost associated with caring for these patients. Two, they're a distinct patient population. They're different than patients that present with endocarditis from other causes. And these patients have a high risk of late mortality that's driven primarily by their recidivism to IV drugs. And finally, in order to successfully manage these patients, really a team approach is going to be the key to taking care of them. This slide here is just a quick review of valvular anatomy. So the picture on the left here just shows the Hardin cross-section at the level of the aortic and pulmonary valves. And what you should note is that the aortic valve is really at the center of everything. There's very little tissue that actually separates these valves from each other, so that infection that sets up in one valve can easily spread to another. The picture on the right here shows the relationship of the aortic valve and the anterior leaf of the mitral valve that actually share a bridge of tissue here known as the aortic mitral curtain, so that, again, infection that starts here in the aortic valve or mitral valve can spread from one area to another. And that can lead to a transesophageal echo that looks like this. This is a patient that presented with endocarditis complicated by a root abscess. So this is the aorta here, the aortic root, and this is the anterior leaf of the mitral valve, and this is a aortic root abscess located right here. And so this patient presents with a really complicated problem. They're going to require, in addition to broad-spectrum antibiotics, they're going to require an aggressive surgical debridement, possibly replacement of their entire aortic root and even their mitral valve. So I've got some data to go over here, and again, we're going to move through it fairly quickly, but I just want to illustrate a few points that I think are important. This is a recent article out of JACC. They looked at 130,000 patients that were admitted with infective endocarditis, and they stratified those patients by drug use and looked at the 30-day readmissions and cause. The data on this slide here shows, up here in A and B, it shows that over time that the proportion of infective endocarditis cases related to drug use are increasing, as are the number of surgeries for these patients. And then graph C shows that these patients are primarily in the lowest income quartiles. And then graph D here shows that these patients are relatively young in age. Okay, so they're relatively low income, young in age, and the incidence is increasing over time. This is from a separate study here. Again, it shows that over time that the incidence of infective endocarditis cases related to drug use is increasing, as are the costs associated with taking care of these patients. This is a multifactorial problem with cost, but in large part is driven by lengthier hospital stays in these patients. This is similar data from a single healthcare system in North Carolina. They showed the same thing. Again, incidence is increasing over time, as is the cost associated with taking care of these patients. This is a table from that JACC paper that I referenced earlier, and there's a lot of data on here. Don't get bogged down, but the point is that these are two completely different patient populations. So the average age of a patient that presents with non-drug related endocarditis in the study was 50, relative to 38 in drug users. And also the incidences of significant comorbidities are lower in the drug use population. So things that we think are important to our patient outcomes, like congestive heart failure, hypertension, peripheral vascular disease, pulmonary hypertension, COPD, diabetes, liver disease, renal failure, all these things are lower incidence in the drug use population with endocarditis. But in spite of that, this younger, healthier population actually does worse over time than non-drug users with endocarditis. And so early on, at 30 days, the mortality is fairly low. for both groups after surgery. But you replace a 25-year-old's tricuspid valve for endocarditis, that patient's risk of death at 30 days is extremely low. But if you follow that same patient over 8 years, as they did in this study, that patient's risk of death approaches 70%. So this is similar data from a center in Sweden. They looked at the same thing. They show significantly worse outcomes in drug users than non-drug users who were admitted for endocarditis over time. This is a study out of the UK. They looked at a NIH database, and they looked at all patients with endocarditis who were admitted that were drug users over a 10-year period. They found that survival at 1 year was 74%. If you follow that out for 10 years, was as low as 44%. And that same study also found that surgery did not necessarily confer any long-term survival advantage to medical therapy for these patients. This is that Jack article that we referenced earlier. It just shows that that these patients with drug-related endocarditis, they have a much higher rate of readmission than other patients with endocarditis and reinfection of recurrent endocarditis. And what we know is that when patients come back with an infected prosthetic heart valve, that a redo operation in that patient is particularly fraught with complications, high risk of morbidity and mortality in these patients when we're doing redo operations for infected prosthetic heart valves. This is a study that looked at native valve endocarditis versus prosthetic valve endocarditis. You can see certainly that the prosthetic valve endocarditis patients do significantly worse over time. And so what's leading to this rise in late mortality in the drug-related endocarditis patients? Well, it's not the things that we typically think of in heart surgery patients. It's not heart failure, it's not coronary disease, it's not COPD or renal failure. The single factor that determines whether or not these patients are alive at 10 years is whether or not they're able to maintain abstinence from IV drugs. And so, these patients come in with certainly a life-threatening problem in the short term of infective endocarditis, and surgery is certainly a critical part of that management. We can replace an aortic valve, a mitral valve, a tricuspid valve if needed to manage these patients. But I think what we've shown is that these patients, have significant hurdles ahead of them with regards to their other medical and social issues, primarily their addiction. If intervention is not taken place in that, especially with the addiction, at the index hospitalization and continued on, those patients are going to do poorly over time, no matter how well their operation goes. And so, certainly, I would argue for a team-based approach, which would include obviously cardiac surgery and cardiology, but also infectious disease, drug addiction psychiatrists, social worker, medical ethics, and in some cases even palliative care. And so, again, just to review the learning objectives, we wanted to go over, one, the incidence of drug-related endocarditis is increasing, as are the costs of taking care of these patients over time. These patients are distinctly different from patients that present with endocarditis from other causes, and they have a high late mortality driven by their recidivism. And again, a team-based approach is key. And I'm going to leave the audience with this. This is a picture of Adam Brown, and some of you may recognize Adam. He's a native of Hot Springs, Arkansas. He was a Navy SEAL, was a highly decorated SEAL, served on SEAL Team 6, and was unfortunately killed in action in 2010, was awarded the Silver Star. And this book, Fearless by Eric Blim, is a great read. I would recommend it. And one thing that it talks about is Adam's struggle as a young adult with drug addiction. And he was able to overcome that with the help of people around him, and kind of face those demons and struggle through it. But these patients that we see with endocarditis-related drug use, they can certainly be a challenge to take care of. They can be very unlovable at times, but certainly they're not a lost cause. And again, thank you. I'm Mark Hardin. Pleasure to be here, and let me know if you have any questions.